So hi everybody, here's our lecture on rheumatoid arthritis and on leukemia. RA, rheumatoid arthritis, is a chronic systemic disease. It's generally accepted to be an autoimmune disease, and it involves inflammation of the connective tissue in the synovial joints of the body, and it's characterized by periods of remission and exacerbation. Sounds familiar, sounds like some other disorders we've been talking about this semester. Rheumatoid arthritis is frequently accompanied by manifestations that occur outside the joint itself, in the structures surrounding the joint, and it occurs throughout the world and affects all ethnic groups. When you're done watching this lecture, do cut and paste these links and watch these very short videos that will sort of help you understand the manifestations of RA and how it can affect people of different ages and how it can really affect quality of life. And it does occur at any time of life. The incidence generally increases with age, but it does peak between the 30s and the 50s. Nearly 2.5 million Americans are affected, and women are three times higher incidence than men. And like I said, we generally accept that it's an autoimmune disorder, but we don't really know the cause. We have not found any infectious agent that causes it. So what we have found is that initially an immune response will be triggered. And that triggering of that immune response forms the IgG antigen, the immunoglobulin, IgG, and then antibodies, known as rheumatoid factor, are formed against the abnormal IgG. This leads to an inflammatory response. So basically what happens is the rheumatoid factor and the IgG combine to form immune complexes. And these immune complexes deposit on the synovial membranes and form this complex that leads to the activation of the inflammatory response. Neutrophils come to the site, like they come to every site of inflammation, and then they release proteolytic enzymes. And these enzymes can damage cartilage and cause the synovial lining to thicken. So over time, what you have is cartilage destruction. You develop granular tissue at the site. The bone begins to erode, and people experience a great deal of soft tissue swelling and pain and joint deformities. So imagine, if you were, say, a 30-year-old person and you developed RA and your hands began to become deformed, like in this picture, and this is a very realistic picture. Imagine how that would affect your ability to work, to drive, the amount of pain you'd be in every day. It can be a debilitating disorder. We also believe that there's a genetic factor involved. There's the human leukocytic antigen, HLA-DR4, in Caucasians, and we have found that there's a higher occurrence of RA in identical twins as compared to fraternal twins. We do know also that smoking increases the risk significantly if you're genetically predisposed to RA already. There's 4 stages basically with RA. The early stage, you won't really see any destructive changes on X-ray, but you might see what looks like osteoporosis. In stage 2, where it's moderate, you still won't be seeing joint deformities. You possibly will start seeing some soft tissue lesions, and your X-ray will show the osteoporosis, but may not be showing any bone or cartilage destruction. with severe stage 3 RA, you will start seeing evidence of cartilage and bone destruction in addition to the osteoporosis. Your joints will start being deformed and you'll start experiencing extensive muscle atrophy, along with the presence of those soft tissue lesions that occur outside the joint. And in stage 4, you meet all the criteria for stage 3, but your joints are basically immobilized and fixed in an abnormal configuration, and you're no longer able to really use your joints at all. The onset of RA is insidious. People often feel fatigued. They'll have weight loss and generally be stiff. Their motion will begin to be limited. You'll start feeling inflammation in your joints, pain. These changes occur symmetrically, and they're frequently in the small joints of the hands and feet. That's where you'll generally see it, but it can occur in any joint at all. Or, it can occur in any synovial joint. It's most common and frequently seen in the small joints of the hand and feet, but it can occur in any synovial joint. Initially, people will complain of joint stiffness after inactivity, morning stiffness. They'll have some swelling of the small joints of their hands and feet. Their joints will become tender, painful, and warm. Joint pain in rheumatoid arthritis increases with activity, and it varies in intensity, and it may not be proportional to the level of inflammation at all. It can be very severe pain, even with what we would maybe consider a moderate inflammation. So one thing that's important with rheumatoid arthritis is encouraging people to stay active, to continue to move their hands and feet even though they hurt. You want to control the pain enough so that they can continue to move those joints, because the last thing you want them to do is to become immobile. So you want to try to keep them moving their joints as much as possible, or as much to keep their joints functional as long as possible. So extra-articular manifestations, these are manifestations of symptoms and things that can occur outside of the actual joint itself, can affect nearly every body symptom. About 25% of all patients who have rheumatoid arthritis develop rheumatoid nodules. These nodules are usually located over the extensor surfaces of joints. They appear subcutaneously, and they're firm, non-tender granuloma-type masses. You'll see them at the base of the spine or the back of the head. That's pretty common in older adults. These can develop insidiously, and they can persist or they can regress spontaneously. They're usually not removed because of a high probability of recurrence. What you need to look out for is that they can easily break and become infected. So just kind of assess them and make note of them. They can also appear as sclera, on the sclera of the eyes or in the lungs. And when they do appear in the sclera of the eyes or in the lungs, they indicate active rheumatoid arthritis and a far poorer prognosis than if they're, say, at the base of the spine or the back of the head. One thing other to know about the rheumatoid nodules is that, like I said, 25% of all patients with RA do develop these, but those affected usually have very high titers of rheumatoid factor. And there's just a picture to kind of illustrate all of that. So without treatment, joint disease destruction begins as early as the first year of the disease. You'll see diminished grasp strength that will affect patients' ability to perform self-care. you'll see like nodular inflammation and muscle fiber degeneration that lead to pain that's similar to vascular insufficiency. Some people will develop cataracts and loss of vision from the scleral nodules. And then we already talked about the rheumatoid nodules. I didn't mention that they can occur on the vocal cords as well, which can lead to progressive hoarseness. So if you have someone with RA who's hoarse, you can kind of understand there may be some nodules going on. And obviously if you have a nodule in your vertebral bodies, it can cause bone destruction in your back as well. In later rheumatoid arthritis, you might see some pericarditis, pericardial effusion, some cardiac involvement, and you can also develop carpal tunnel syndrome from this. So rheumatoid arthritis is defined as having at least 4 of the following 7 criteria present, and these 4 criteria must be present for at least 6 weeks. So I won't read those, but you can see to have 4 of these present for at least 6 weeks, they're probably going to run a rheumatoid factor if they haven't already, to just see what's going on and to give you a definitive diagnosis. You usually will do a history and physical, find out about what kind of pain they're having, when it's occurring, what happens when when it's occurring. Sometimes you'll want to go ahead and do some laboratory tests because, like I said, the positive rheumatoid factor occurs in 80% of patients, and titers rise during active autoimmune disease. So you're going to check your ANA titers. You're going to check your sedimentation rate and your C-reactive protein because those are indicators of active inflammation. And you're going to look at x-rays to see any evidence of joint space narrowing or bone erosion. Things that you're going to think about with your rheumatoid arthritis individual who's suffering from RA is there's no special diet that will reduce the incidence of RA or improve their symptoms, but it's important that they maintain balanced nutrition to just maintain healing and to help their bodies with the stress. You know, you're just normal balanced nutrition. There's nothing that you can take out of your diet that's going to help it go away. You do want to actively look for ways to improve their pain. A lot of time they'll be on NSAIDs. Many of them will use aspirin or cold packs to manage their pain, especially people who are still like very active. And remember, that's one of our goals with our RA patients is to keep them as active as possible. And so what you'll find is that sometimes folks will take NSAIDs or use a cold pack before they have activity or exercise so that they can tolerate the activity better. It will keep them active. You can also have them go to physical therapy or occupational therapy to find ways to cope and also to keep their hands active. They can be taught exercises. It's very important that they follow their dosing recommendations for their medications and that they go to their laboratory and medical follow-ups because they do need to be monitored when they're on RA medications. And I think that's really all I wanted to say there. The one thing that I did want to say is while you want them to stay active to maintain the joint function and not lose joint function, you do want them to avoid repetitive activities. So if someone is a typist, you may want them to not type as much, maybe use some kind of voice recognition software when they're writing. So avoid repetitive activities, but stay active. So it's important to have an accurate diagnosis because this is essential to initiate appropriate treatment and to prevent unnecessary disability. But what we've found now that what they used to do was they would maintain people on high doses of aspirin or nonsteroidals until the x-rays showed clear evidence of rheumatoid arthritis. They used to do it that way. Now they will more aggressively prescribe disease-modifying anti-rheumatic drugs, because we know that irreversible joint changes can occur as early as the first year, and we would rather get the jump on this and start treating it prior to that damage being done. So sometimes they'll base it on lab work and go ahead and get started on your DMARDs is what we're calling them now, disease-modifying anti-rheumatic drugs. So we're starting those sooner rather than later now. The drug therapy for this, NSAIDs and aspirin, and again the disease-modifying anti-rheumatic drugs, the most popular of which is methotrexate. And then we can also do the biologics. These can slow the disease progression as well. When people develop symptoms and acute exacerbations, we can start steroid therapy to aid in the symptom control and to reduce that inflammation even more. Our overall goals with rheumatoid arthritis, we want to keep their pain relieved. We want them to experience minimal loss of the functional ability of their affected joints. The longer they can move their hands, the longer they can move their toes and feet, the less likely they are to become immobile or dependent on someone else to carry out their ADLs. We want to discuss the treatment plan with them and how they can carry out the therapeutic regimen. We want to help them maintain a positive self-image, get them in with support groups. It can be very devastating to have something that everyone can see happening, your hands being changed and taking on a deformed appearance can be very tough for people. And so we need to provide them the kind of support and support groups that will help them with that. And our big goal is that we want them to be able to maintain and perform their own self-care. And right in line with this, we're going to decrease inflammation, manage pain, maintain joint function, and prevent or correct joint deformity. Those are our primary goals. We're going to be doing kind of a comprehensive program utilizing all of these things. We're going to be giving them their drug therapy, rest, and they should go to PT for an individualized exercise program for the joints that are involved. Teach them how to protect their joints, teach them about therapeutic heat and cold. There have been some successful uses of biofeedback and the transcutaneal electrical stimulation as well as hypnosis. And then, as always, we're going to provide patient and family teaching and psychological support. And sometimes it's as simple as listening and just allowing them giving them space to just open up and talk about how things have changed for them or ways they're coping. And it's really important for us to be the ones who provide that space.